This is the second half of chapter 23. It covers more neurological diagnoses, starting with the nervous system on page 533 in Leifer. So, more or less some facts about your pediatric nervous system. The brain constitutes 12% of a newborn's body weight, compared with only 2%, of course, of an adult's body weight. An infant has 50 milliliters of cerebrospinal fluid versus an adult has 150 milliliters of cerebrospinal fluid. Peripheral nerves are not completely myelated by birth. So coordination and fine muscle movement is not present at birth. Head circumference in a term infant is 34 to 35 centimeters. Primitive reflexes such as the Neuro reflex, grasp reflex, rooting reflex, present at birth disappear at various times during the first 5 months, when these primitive reflexes reappear with certain neurological diseases. So that's some information on some statistics on the neurological system. So the nervous system itself, everything going in is sensory. Everything coming out is motor. Think about some high-profile ethical cases. If your body's completely normal and you're in a coma with your brain functioning gone, your brain dead, they pull the plug a lot of times, or they make you a DNR, they donate your organs and you die, versus if you have a brain and can function, but you don't have the rest of your body, like former Superman Christopher Reeves kept alive for years and years and years because he had a functioning brain, but he didn't have a body to support it, but he was still alive because he could think and have thought process and communication and feelings and everything. So nervous system, neurological system, one of the highest, most important body systems in our body. It consists of the 12 cranial nerves. Picture a visual, figure 23-7 on page 535. We do things called neurological checks, where we check pupillary function, we check motor skills, reflexes, coordination, balance, pupils, those types of things with the neuro checks in the hospital. There's the Glasgow Coma Scale, which is at the end of chapter 23. I already pretty much covered Pearl or Perla. We'll mention it again at the end. Your reflexes, reflex charting, a lot of times done by the health care provider or the physician, pediatrician. Coordination testing, like finger to nose testing, have them touch your finger and back to their nose, and then balance testing that tests this cerebellum and cerebellar function. So big system, big chapter, so I'll try to just pull out the highlights. So Reye's syndrome, life-threatening disorder, life-threatening, involves changes in the liver and the brain. I might have mentioned in section 2 about ammonia levels and PKU. Well, I got that mixed up. I got a visual here for you. Reye's syndrome causes problems, fatty changes with the liver. It causes cerebral edema, which can cause an altered LOC, and we prevent that by not giving aspirin or salicylate containing products to children, and I wanted you to see this visual on that. So with Reye's syndrome itself, they can develop encephalopathy, which is inflammation and swelling of the brain, and hepatotoxicity or hepatopathy, which is pathology in the liver origin. A lot of times what happens is the child develops a virus in the peak viral season, of course, of influenza, like we're in now, that's treated with a salicylate or aspirin, and it causes the child to go into Reye's syndrome. This was a scare when I was a child because your mother always gave you aspirin or a baby aspirin containing products, because I'm pretty sure ibuprofen wasn't invented. I did not research that well enough, but you were stuck with acetaminophen or aspirin, and a lot of times you got aspirin when you were a kid. So this can cause it affects the liver and brain. The accumulation in the brain can cause ammonia buildup. We can check a serum ammonia level. The patient will show like combativeness, irritability, confusion, those types of things. So the signs and symptoms are this ammonia buildup, effortless vomiting or profuse vomiting. Not like someone's going to be nauseated. They just start vomiting. Altered behavior, seizures, loss of consciousness, progressing to a coma. Infants can show changes in vitals and blood glucose. So very, very serious disease. Again, accompanying a recent viral illness. Prevention: no aspirin, no Pepto-Bismol. If you turn over the back of the Pepto-Bismol bottle, it will say, may cause Reye's syndrome in children, do not give to children. Diagnostic-wise, we're going to see an elevated liver enzymes. Those are your ALT, AST levels. Those are a serum blood draw. We'll see a serum ammonia level elevated. Because the liver causes blood coagulation, you may see altered coagulation studies. So your coagulation times will be too long or prolonged. So you'll have bleeding, bruising. They may do a liver biopsy. We may collect cerebrospinal fluid just to rule out the encephalopathy or meningitis, the neurological pathology. So treatment would be they can recover completely if caught early. So reducing increased intracranial pressure, reducing the ammonia, monitoring coagulation, so no like bleeding precautions, no sticks if possible. They may need intubation and mechanical ventilation, which would be an ET tube in their throat on a ventilator. Seizure precautions, those types of things. So we don't see this much anymore, but supporting the family in grief if death would occur. So very, very serious finding, Reye's syndrome. I have myself never seen it in real life on a child presented anywhere. But we have to do the prevention or the teaching of no aspirin or aspirin containing. So the next one is sepsis. Sepsis is a body system-wide infection, a systematic response, activates your systematic inflammatory response syndrome. It can cause tissue damage, which leads to septic shock and death. Sepsis, anaphylactic shock, hypovolemic shock, cardiogenic shock, neurogenic shock, they all lead to the same type of destruction of tissues at the cellular level and death. So what types of children would be at high risk for sepsis? Children that are immunocompromised, so children with cystic fibrosis, children with chronic respiratory ailments, pneumonia, asthma, children that are being treated for cancer that are neutropenic. They don't have neutrophils or white blood cell count because it's being destroyed by the chemotherapy they're getting to kill the tumors in their body if they're cancer patients. So those types of kids would be high risk to develop sepsis. Now these kids that are dying currently from influenza, because we're having like a horrible influenza, a lot of them are going into sepsis. It's like they get influenza, then it goes into pneumonia and septic shock, like almost just boom, boom, boom. You don't get any kind of prelude or preliminary symptoms or pathology that you can catch it. It's like they just have this SIRS kick in and they die. So these patients can have fever, tachypnea, which is elevated respirations beyond where their normal number is for their gestational age, elevated pulse, changes in levels of consciousness, altered levels of consciousness. So not being alert and awake and oriented, decrease in blood pressure, decrease in urine output is another sign that your book didn't list. Hypotension is an ominous sign, indicates the body is unable to compensate. It's also, unfortunately, a late sign with poor outcomes. Laboratory tests will test their blood in the form of a blood culture to see what circulating organism is causing it. You'll see an elevated white count, elevated neutrophil count that kind of goes along with that inflammatory process of the fever. Neutropenia, I want to say that your body can produce so many neutrophils, which are new white blood cells, in the form of your band cells, that they send them all out into your circulating blood. So your textbook mentions they might be neutropenic, meaning their neutrophil count is way below normal. And that's because they've already sent them all out into your bloodstream and they don't have any reserve left. They send them all out when they're too young or babies. They don't get to grow into a full-blown white blood cell. They send them out way too young, and your body does in response to this horrible, massive system-wide infection. And so you'll see on the blood draw neutropenia, low neutrophil count. Prevention, it talks about influenza type B, the Hib, and the pneumococcal conjugate vaccine, the PCV, that are recommended for all children between 2 months and 4 years of age. Haemophilus influenza type B, serious disease caused by bacteria, can strike a child under 5 years old. Your child can get this by being around other children or adults who have bacteria and aren't sick and don't even know it. The germ spreads person to person. It can get in the child's nose and throat. But then when it spreads to the lungs or the bloodstream, it can cause serious problems. So the Hib vaccine is recommended to children starting at 2 months of age, 2 months, 4 months, and then possibly another dose around a third or fourth dose around your 12th to 18th month of age. And then your pneumococcal conjugate vaccine, or your PCV13 or Prevnar 13, is recommended to protect infants and toddlers and some older children with certain health conditions from pneumococcal disease. It's caused by strep pneumonia bacteria. They can also spread through person to person through close contact. So these vaccines can help prevent sepsis. And sepsis can also be the source of other types of a bacterial origin also. So moving then on into inflammation of the meninges or meningitis. Meningitis is another disease that is kind of mentioned in your ATI book. It can be caused by bacterial, viral, or fungal origin. Fungal is very rare. Most of the times it's bacterial or viral. Haemophilus influenza, again, is the most common organism. It gets into your meninges directly by way of bloodstream. Bacterial is considered purulent because it's pus forming. These kids can have, actually, they can die from bacterial meningitis. You can have increased intracranial pressure, those types of problems with meningitis. So there are less cases of it now because of the vaccines that prevent this disease in infancy. So the signs and symptoms we see. So bacterial versus viral. The symptomology will present the same. The only way that we can tell the difference is usually from a lumbar puncture or a spinal tap. And so that's kind of how we're going to prevent or to diagnose. So symptoms include a severe headache for a child that can say they have a headache, drowsiness with delirium, irritability, restlessness, fever. They have stiffness of the neck. They cannot take their chin and put it down to their chest. That's a sign that we usually ask the child, can you take your chin and put it on your chest? And if they can't, if they have a stiff neck, that's called nuchal rigidity. That's a term that you need to be familiar with neurological diseases of your meninges and your brain in general, encephalitis. You will see a positive Brudzinski's and Koenig sign. And these are not end-all be-all. So they're saying, you know, the doctor might perform this in a clinic setting, ruling out, or an emergency room, but you're probably going to get, obviously, the cerebral spinal fluid check from the lumbar puncture to be for sure. So the Brudzinski sign would be severe neck stiffness that when you lift, again, your chin to your chest, it causes your hips and knees to flex up because, of course, everything is becoming rigid in your cerebral spinal environment. Sorry, I got a phone call I had to take. Your other positive sign is your Koenig sign, and you're unable to straighten your leg greater than straighten your leg out without severe pain. So those are a couple of signs that you can connect to meningitis that maybe, I mean, they're in your ATI book, so you may have to know them for your pediatric ATI exam at the end of the PEDS class. So photophobia, high-pitched crying infant, shrill, bulging fontanelle is a late sign. This petechial rash, that one is connected to bacterial meningitis. And I have the glass there because it's a petechial rash. This is what it looks like. And you can put a glass against the skin and it doesn't blanch. So it's a non-blanchable rash. Those are way more serious than if the rash blanches. So that one, the rash, you connect to bacterial. There's our diagnosis, the lumbar puncture, and you're going to see with the cerebral spinal fluid, if it's bacterial in color, it'll be a cloudy looking CSF in the collection containers when they're doing the test. If it's viral, it will be clear. Obviously with bacterial, you'll have a high white count, those types of things. So treatment, if we think any type of meningitis, the child goes into droplet isolation until we can perform the lumbar puncture. If the origin is viral, we can take them back off of isolation. But if it is bacterial, they stay on isolation, and anybody that's come in contact with the child has to be put on prophylactic antimicrobial therapy. So very, very serious. Nursing care, medications, we will deliver antibiotics in the form of an IV antibiotics. They will get possibly IV steroids for inflammation, like in the form of corticosteroids or Solumedrol, analgesics and antipyretics in the form of acetaminophen or ibuprofen for the high fever that can develop. Neuro checks. We want to maintain a quiet environment to help decrease stimuli with the patient. We want to put them in, of course, droplet isolation, strict I&O, monitor their level of consciousness, report any signs and symptoms of increased intracranial pressure. We want to possibly, they may be NPO if they have a decreased level of consciousness. Quiet environment, no bright light, cool room. May position the client without a pillow, and they may want the head of the bed slightly elevated. Just depends on the doctor's orders. That's really it on meningitis. It is a big one. Encephalitis is inflammation of the brain. The spinal cord can be affected also. And so causes can be a viral infection. The exact cause of encephalitis is unknown. Most commonly diagnosed is post after a viral infection or following an upper respiratory infection. That's what a URI stands for. It can be a complication of having measles, mumps, German measles, rubella, which is measles, those types of things. And symptoms almost following the same as meningitis or your inflammation of your meninges. So you're going to see seizures, headache, altered level of consciousness, the nuchal rigidity again, neck stiffness, muscle twitching. You may see nystagmus, which is abnormal eye movements. The treatment is very supportive. Relief from specific symptoms, so antipyretics and analgesics from just muscle stiffness and pain. You may have seizure precautions, provide adequate fluids and hydration. Again, if the patient is in any type of altered LOC, they may be NPO. Oxygen can be administered as needed per order. And you can observe the child closely for altered LOC. And then they mention brain tumors. Target age is a school child. Increased intracranial pressure are the hallmark signs and symptoms. Pretty much if you develop any type of a tumor, you have a couple treatment options: surgery to remove the tumor, chemotherapy, and radiation. They do some newer treatments like with biological response modifiers and interferon, and cancer care is getting more and more tumor, and they test the tumor and it's tumor targeted specific. If the child gets radiation, they may have to outline areas to be treated on the child's head, and they've got in dark print on page 539 not to wash those marks off because they're marking exactly where they're going to place the beam to give the radiation to that portion of the brain. A lot of times palliative care is an option, referencing the chapter of the dying child, which is something that the chapter in this textbook that no one wants to read, but palliative care may be the only option depending on the location and the type of neoplasm or tumor in the child. Next is seizures, seizure precautions, and chapter 13 in your ATI book, which starts on page 69, they have a complete small little chapter devoted to seizures. So you know you're going to have a seizure question or two on your ATI. So most commonly observed neurological dysfunction in children. So the etiology, of course, is very huge and broad. It can be intracranial in the form of epilepsy, a congenital anomaly like hydrocephalus or spina bifida, the birth injury that caused the seizure. It can be extracranial in the form of a seizure, a metabolic disorder, an electrolyte disorder, and things like that. Or it can be toxic due to a drug overdose or poisoning, giving anesthesia. Those types of things could have caused a seizure. So you have a sudden intermittent episodes of altered LOC, which is what ALOC means here on the slide, that last seconds to minutes. Your textbook mentions febrile seizures, and it can occur in response to a rapid rise in temperature, often above 102 or greater. This can be just a one-time only. Fever got too high, it happened too quickly. We usually recommend the use of antipyretics, removing heavy blankets and clothes. Usually it's self-limiting and was just caused by just another, of course, origin. Types of seizures, these are listed on the table 23-2 on page 540. They're also listed in your textbook or in your ATI book. I just kind of I made this chart, this general, to kind of just break it down because it can be overwhelming. And the term grand mal is not used anymore. That is your tonic-clonic seizure. Grand mal, again, is not a term we use anymore. A lot of times this has an onset without a warning. They have what they call a tonic phase, a clonic phase, and a postictal phase. Tonic being stiffening, contracting, loss of consciousness, increased salivation or foaming at the mouth, apnea, those types of things. Then we have the clonic phase. So tonic is stiffening, eyes roll, loss of consciousness, tonic contraction of the entire body. And then you move into the clonic phase, which is alternating contraction and relaxation of muscles. You'll see violent jerking. This is the one, the clonic phase. You can have foaming in the mouth. They can lose continence of bowel and bladder. And then you have a postictal stage, which is a short period of sleep where the child is semi-conscious, maybe a little confused. They sleep for several hours. They're very tired. They complain of the sore muscles. So that is the first type. The tonic-clonic is what I want you to refer to that as, or the generalized seizure. And then we have a seizure called an absent, and you don't pronounce it absence, it's absent. Formerly called petit mal, so we're not going to call it petit mal anymore. And this type of seizure, the child can have a blank stare, or they seem to be daydreaming, or they can just constantly chew or blink over and over again. And this can be often mistaken as like lack of attention on a child or ignoring an adult when really they're having a seizure. So blank stare, chewing, blinking motions, absent seizure. And then your book talks about a partial seizure, and they break them into a simple partial and a complex partial. Accounts for 40% of the childhood seizures. Consciousness may be intact or slightly impaired with jerking area movements of one area of the body only. So a simple partial is also called a Jacksonian, often mistaken for a tic, and it's not. It's actually a seizure. It can involve only, say, the face or a shoulder. The patient a lot of times stays awake with a Jacksonian or a simple partial seizure. With the complex partial seizures, starts with the blank stare and chewing. The person becomes unaware of their surroundings. They may become clumsy or pick at something or try to take off their clothes or run or be afraid. I've seen some of these complex partials on YouTube. I know of someone, an acquaintance of mine, her son has complex partial seizures. So a lot of times your absent and your partials can almost be wiped into the same group. And the last form your book goes to mention is your atonic or your myoclonic seizure, infantile spasms. More frequently occurs in the morning. I put in the AM with jerking motions, and then the person will collapse. This may be mistaken for the child is just clumsy. Clumsy and they can't walk good. They're just drunkenness, those types of things, and it's not. It's an actual atonic seizure. So those are your different types of seizure categories. As far as treatment, before we treat, we have to diagnose. So what will happen is the patient will go through a CAT scan, CT scan, or an MRI, possibly look at to rule out tumors or skull abnormalities or intracranial calcifications. Rule out some lab work to rule out poisoning as a cause of the seizure. And then a lot of times we will have the patient, the child, have an EEG, an electroencephalogram. And that is the procedure where the patient, I think your ATI book talks a little bit more about your EEG. And it can last an hour or so. This is where you would actually abstain from caffeine. You want to wash your hair before your procedure, and because they're going to put these little electrodes all over your head, and it's going to monitor more or less the wave conduction of your brain. They may do a lumbar puncture. I didn't list it here on the slide. Treatment would be in the form of anti-epileptic drugs or anti-seizure drugs. So those consist of, there's a drug class called anti-epileptics, and there's a whole chart of those on table 23.3 on page 542. So anticonvulsant therapy you have to take at the same time every day. There was a young girl in middle school during a track meet, was running a track competition, a running competition, and fell and had a seizure. Of course, it was a tonic-clonic. Of course, during the postictal stage, we of course got her off the track. She, of course, was sleepy and better, a little bit confused, but come to find out, she was not taking her anticonvulsant medicine. She didn't want to take it because she didn't have seizures, so she didn't feel bad. And then, of course, she had the seizure again. So drug compliance is a must for kids that need the medication. So there are several different types of anti-seizure medications. Some of your basic nursing education would be to take it the same time every day. Don't stop taking it suddenly. If they do order the drug Dilantin, it's kind of an older drug. You need to give vitamin D and folic acid supplements. And that's on a medication safety alert on page 541. So your drugs are listed on page 542 in that table. And I do know that your basic anticonvulsant therapy, they can draw serum blood levels to check compliance with the drug and to check that the drug is in therapeutic range. They try to only give one medication only. Some of these drugs will cause GI upset or liver stuff, so you may have to have liver enzymes monitored. They can cause drowsiness. So again, the child sometimes doesn't want to be compliant with taking them. If you look at the box on Dilantin, it talks about gum overgrowth. So you may need to see a dentist. And gum disease and hyperplasia of the gums. So you have to watch for that with Dilantin. And they actually show a picture of the gums on page 543. So you can see what Dilantin would do to your gums, the hyperplasia. They will sometimes give benzodiazepine drug class 2 during an initial seizure, like a tonic-clonic in the hospital, in the form of diazepam or Valium, something like that also. And as your child grows, that change in the med might need to occur. Diet changes, they talk about a ketogenic diet. The diet would be high in fats, low in carbs, with a consistent amount of proteins. This produces, the ketogenic diet produces ketoacidosis, which can reduce convulsive episodes, possibly. The ketogenic diet more or less can be tried. Reduction of fluid intake, it tends to increase the ketogenic effect. So this diet may be, and this long-term effects with your lipid panel and stuff with this type of diet has not been studied. But I do know some kids are successful with that. And then they may have surgery. They may need to remove a tumor or a lesion causing a seizure. And they may get something called a vagus nerve stimulator. It's implanted into the chest wall and connected to your vagus nerve. And it stimulates to try to combat or prevent seizures from occurring. That vagus nerve stimulator is an option, and it's kind of a newer treatment. Safety alert with seizures is on page 542. You're supposed to keep side rails up. You pull things away from the person if they're having a tonic-clonic to where they would not be harmed or hurt. Remove glasses, things like that. Make sure the child's wearing a medical ID bracelet. Never, never try to restrain or hold a child during a seizure. Never try to insert an airway or insert. Back in my day, believe it or not, they took a tongue blade, a wooden tongue blade, and wrapped it in gauze wrap. And when the child had a seizure, you were supposed to stick that in the mouth. Now, does that even remotely seem safe? No. So that's why every one of your books now will say, do not insert an airway. Because at one point back in the day, we did. And that's an evidence-based intervention that we've come about like over time. Like, hey, let's not do this. It makes no sense for me to have ever done that. You want to avoid a triggering factor if there is one. And hazardous play such as swimming if someone's prone for seizures, or you would have to have, of course, constant supervision. It may affect your driver's license in certain states, so your teen population would be over devastated if they could not drive or had to have a certain seizure-free period. They really need to wear a medic ID bracelet, because if they're seizing in Walmart or McDonald's, so we know what's going on with the child. Status epilepticus, that is mentioned on page 543. This is severe. What happens is the tonic-clonic seizure, and then it doesn't stop. It can result in death. You would need to call 911 If a seizure lasts over a minute, if your seizure would last over, I'm going to say, a minute to 2 or 3 minutes, it would need a call to 911. So these kids will be intubated in an ET tube and mechanically ventilated on a ventilator. They will need IV anticonvulsant medication, IV benzodiazepines in the form of Ativan or Valium, the diazepam is its generic name. And they may get this rectal diazepam. I copied and pasted a picture so you could see it. It's really hard to start an IV on someone that's seizing. So you're going to take rectal diazepam and you're going to put it straight into their rectum and squeeze just like you would an enema. And that will stop the seizure from happening. So I'm going to just pause real quick. Cerebral palsy is this non-progressive disorder that affects the motor centers in the brain. It's a number of neuromuscular disabilities associated with cerebral palsy. Alteration in voluntary muscle control related to a cerebral insult of some kind. So cerebral insult causes can be a birth injury, neonatal anoxia, not enough oxygen right at birth, subdural hemorrhage, infections, head injury. These can all cause cerebral palsy. And so signs and symptoms, possible varying degrees of developmental delay, feeding problems, convulsions, seizures, developmental milestones not achieved, ataxia, and which is like an uncoordinated movements. There are 4 different types of cerebral palsy identified in your textbook on page 544. Spastic, dyskinetic, ataxic, and then mixed, which is spastic with the dyskinetic together. This diagnosis is lifelong, limited, causes permanent disorders, permanent developmental delays, permanent muscle spasticity, affecting, of course, those motor centers. A child with cerebral palsy can have normal brain functioning, or they can be mildly mentally retarded or developmentally delayed. It just depends on the cause or what happened that caused the diagnosis of cerebral palsy or cerebral palsy. So complications, complications are listed on feeding problems, speech problems. So more or less, the treatment plan needs to be highly individualized depending on the problem that specific child is having. So more or less your goal is to assist with the maximum potential. The parent, it's not uncommon for the parent with cerebral palsy to be the experts in caring for their child. There's a whole section that talks about community resources, a religious affiliation, stress and role strain on the caregiver. So these children may be on anti-epileptics for the spasticity problems, levodopa, baclofen pump, which is inserted into, that delivers baclofen for spasticity. So drugs to combat spasticity, physical therapy in the form to prevent contractures, good skin care, preventing contractures by changing positions frequently, use of splints and orthopedic braces, passive range of motion, active range of motion, stretching exercises. They may need communication aids in the form of voice-activated apps on iPads and computers. They may have feeding problems. They may need special utensils, manual control of the jaw, like in the picture on page 546. They may need a gastrostomy tube placed so they can get feedings straight into their stomach. So swallowing and sucking is difficult. Vomiting is a problem. Aspiration pneumonia is a problem. Infants moving on to solid foods is a problem. Children sometimes can be taught to manage that special feeding equipment as they grow. It's important too, with your attitude as a nurse, to be natural and treat these children in a natural manner. Talks about play. All children need play. So play specific to whatever that child can do. Maybe in the form it mentions of finger painting. These children cannot do fine muscle movement activities like sewing, Legos, coloring, fine, small print, things like that would just be frustrated for those children. They need adhered to a schedule. There is a skill box that talks about feeding precautions and pediatric feeding techniques on the rubber-coated spoons and how to stroke under the chin to get the child to stimulate to swallow with the feeding difficulties and things like that. Treatment protocol box for cerebral palsy is on page 546. Then I'm going to skip straight into the head injuries. So head injuries are on page 548. Head injuries in infants, so motor vehicle accidents, not wearing a child restraining, child seatbelt, children rolling off of a changing table, head injuries, things like that, in small infants and children. Bike riding can cause a head injury in a school-aged child. They have a bicycling accident. Rough sports and the contact sports in the form of football are a high profile in the media now. So a child's response to a head injury can be different from that of an adult. We look for changes in level of consciousness, any form of amnesia where they would forget, confusion, changes in behavior. I know a former nursing student of mine had a child that got in a biking accident and he had a complete change in behavior. He got angry and aggressive because, of course, your emotions and behavior, your emotions are stored and your reactions to your emotions are stored in your brain. And he actually had to go to Neuro restorative in Carbondale, inpatient therapy for a while. And I remember this mother telling me this was a middle school age child, that she was frightened for her life from her child because of his severe change in behavior, all due to post-concussion, post-syndrome / head injury. Other symptoms, changes in processing information and recall, memory, trouble walking with balance or gait, the motor portion of the brain, trouble with speaking, of course, the frontal area of the brain where we speak, or understanding speech. So those are all changes. The child may be sleepy. Those would kind of be acute, that would be an acute head injury symptoms. So the 4, they talk about neurological checks and level of consciousness. So you want to check on page 550 the level of consciousness of the child. Again, we talked about they could be from the child being alert and oriented to becoming drowsy, to not being able to stay awake. They're falling asleep when you're speaking to them. Irritable, lethargy, stuporous. So you're needing to elicit a painful stimuli to get this child to wake up. So that would be considered level of consciousness. Level of consciousness is one of the factors of the 4. The pupils and eye movement. So that's another one. So pupil checks and eye movement. It talks about pupils being pinpoint, can be damage to the pons or the brainstem, which would be a horrible finding. Or it can indicate drug toxicity. Pupils that are dilated can mean hypoxia, which is not enough oxygen, or intoxication with atropine-like drugs. Pupils that are unequal can mean a brain herniation, where the brain is actually pulling to one side from all the increased intracranial pressure or swelling. And unequal pupils would be considered an immediate response. Then you have changes in vital signs. We talked about the falling blood pressure, an increase in blood pressure, but hypotension, of course, is an ominous or late sign of a head injury. A decrease in pulse, that widening pulse pressure, that's taking the systolic minus the diastolic. And if that number becomes wider and wider, that is increased intracranial pressure. Your temperature can fluctuate when you get a head injury. You can become, your temperature controls are in your brain, so you can become hyperthermic or hypothermic and unable to regulate your temperature, which is controlled by the hypothalamus. And last but not least is your motor activity, which is part of the Glasgow Coma Scale, where you can either obey commands, where you're asking them to lift a leg or arm above their head or out in front of them, versus a flexion or an extension response. So let's briefly talk about that, then I'm going to bop back to that slide before this one. So we see posturing with a severe brain injury, as in this picture A or B. I want to show you something here, just another mnemonic to help you remember. So this is decorticate, and when I think of decorticate, I think of to the core. It says your arms wrap like a cord, or they move towards the middle. So I think of decorticate as to the core, and this is problems with the cortex of the brain. The cervical spinal tracts, going from the brain down through the vertebral column. And then you see decerebrate posturing, and that is problems with the midbrain or pons. So when you see this posturing on your motor response, the decerebrate posturing is a worse finding than decorticate posturing, because you've got problems with your midbrain or pons. It's a more severe, it's a brainstem injury. So when we talk about this posturing, this can develop in response to a painful stimuli. So if you look at the Glasgow Coma Scale on page 553, they're not a number 5, which is obeying commands, and they're not withdrawing, but they're in flexion or extension, which means the posturing or the flexor posturing. And so those are bad signs to see that posturing in regards to a motor response. So they don't move at all on command, or they don't withdraw from a painful stimuli, meaning you pinch. It talks about in that box 23.6 on page 551, you either pinch a large muscle mass at the angle, the trapezius muscle at the angle of the shoulder and the neck, or you exert pressure on the eye orbits, and they don't, in doing that, they develop this posturing. They can't localize pain. Like a normal person, when you pinch them up on that muscle, is going to reach with their arm to whack it away, even if they're not alert. Whereas if you pinch them and they do this posturing, those are both bad signs, but the decerebrate posturing is a way, way worse sign. So, so those are your 4 findings: your LOC, your pupil and eye movement, your vital signs, and your motor functioning when it comes to assessing for head injuries. So the pathology of a head injury, we will see things like the coup contra coup they mention, which your coup is your head, your blunt force, or your immediate hit of the wind, more or less of the windshield, but your contra coup is where you go backwards and your head jerks the opposite direction. And you can see that if you're hit with a bat, your head's going to actually hit the bat forward. That's your coup, and the contra coup would be the back portion that would, the opposite side of the brain that's affected or torn or a tear. You will see hypoxia, the increased intracranial pressure, and infection that can occur. So we're checking the child for these symptoms and post-concussion. I also wanted to pull up the concussion protocol. So this is the Illinois High School Association implementation of rules for playing with a concussion. So you sign this now when you have a child that plays sports, and you can see these behavioral signs indicative of a possible concussion. Again, the change in LOC, confusion, changes in behavior, personality, or recall, which is memory, headache, nausea, blurred or double vision, balance problems. So if you were to see any of this, it gives you some guidelines, and the child has to sit out of the sport for X number of days now. I haven't read this verbatim, but there are rules now that you cannot just, they have found that the post-concussion syndrome and chronic traumatic encephalopathy caused by repeated head trauma can be associated with Parkinson's disease and Alzheimer's. And there's been information in the media of, I don't watch sports, but a football player that actually his behavior changed and he killed someone, all due to being hit in the head too many times. So this can happen. Your Glasgow Coma Scale, let me see if there was anything else I want to say on that one. I don't think so. That's your concussion protocol. It talks about the sports concussion assessment tool, and the standardized assessment of concussion tools are available to see if the person is experiencing a concussion and when they can come back in to play. Legislation, more or less, is getting involved with concussions. I don't know if that's a good thing or bad thing. Your book defines shaken baby syndrome and what happens with that. I know in the media there have been several males and females jailed recently in our area due to a baby, of course, dying ultimately from shaken baby syndrome. In that situation, you would want to teach the parent coping skills of a child who cries, more or less support groups and things, so you can support from other parents and things for troubleshooting when a baby just won't stop crying. And they talk about jumping on a trampoline as compared to with with injuries repeated, same almost as a shaken baby syndrome type trauma. Cerebral spinal fluid leaks, if the person was in a motor vehicle accident or any kind of trauma, you would look for clear liquid coming from the nose, coming from the ears, and you would test that. You would test that in a dipstick test to see if it's actually cerebral spinal fluid. It will produce a halo-like effect. Or blood that's coming from the nose or the ears. If you dip it onto paper, it'll show a glow or a halo, they call, around that. And that is signs of leaking cerebral spinal fluid, which would be a serious brain injury. There is neurological monitoring of infants and children, the box on page 23-6 that you need to read through. It just goes over the painful stimuli and arousal, motor response, posturing, and all that, and the eyes again that we're looking for with the head injury. And then the Glasgow Coma Scale, which is on page 553. If you look at it, it actually breaks it down in the age of the child, so you can more or less adapt it to a child, because we use the Glasgow Coma Scale on adults also. So this would be a way you could vary it for children of whatever month or age that they are. And the Glasgow Coma Scale actually scores the person in the best eyes opening, motor response, and verbal response. So we get a score from this, and we can all kind of put an objective number on subjective data. So the lower the score, the deeper brain trauma, head trauma, LOC, coma there is. So I got a mnemonic for you to remember. So a normal Glasgow Coma Scale score is a 16, I do believe. 5, 6, 7, 8, 9, 10, 14, 15, 15. And so pretty much if your Glasgow Coma Scale is less than 8, it requires immediate intervention. And so what we say is less than 8, intubate. So that will give you a mnemonic to remember that. So we can then do this Glasgow on initial visit to the ER or to the peds floor, and then compare it to multiple times later to see if there's been a change in neurological status. So really, and then there's a care plan with altered LOC on page 554 to look over. So that is it for me with this, and that was a lot to take in, but pretty much this chapter's at an end. Thank you.